I will call to order this sixth meeting of the Health Working Group. Thank everyone for being here today. Thank the members for their tireless dedication to continuing to show up and put in the work that's required here. I know life is getting busy back home. A lot of things going on in the district. Schools are back in session, which keeps us all busy with events. So I thank you for being here, and I thank you for the work that I know that you guys are putting in between the meetings. So without further ado, we will turn it over to our program today. In my mind, we kind of have two sections that we're going to work through today. And I've asked our presenters, and I thank you guys very much for your flexibility and kind of helping make sure that we answer not only the things that I guess when we first started we wanted to talk about, but there have been a lot of questions through these first 5 weeks just about the Indian health system and how it works and why it works that way and a lot of those things. And so just kind of for everyone's knowledge, we're going to start with information on the Indian healthcare system. It seems like every meeting so far, a question's been asked about whether these people are counted as insured or uninsured. And so we'll get a definitive answer to that. But also, I hope a whole lot of background on why these people are counted and treated in the way that they are, and kind of what that health system provides and what it doesn't provide. So we're going to start with that. After we get done with that, and we'll have ample time to ask questions, and really I think we've got to get our head around an understanding of what tribal health care looks like and how it interfaces with the state and federal government, because it's, to say the least, complicated. After that, we're going to look specifically at Medicaid and how the tribal health system works with Medicaid, because it's different than anything else. Different payment matches, everything about it kind of interacts different because we're talking about sovereign nations providing that care. So we're going to have kind of those two different conversations, but we'll start with this conversation about the Indian healthcare system. Our speakers today are Melissa Gower. She's a senior advisor and policy analyst for the Chickasaw Nation, and Melanie Forkiller, senior policy analyst from the Office of Self-Governance from the Choctaw Nation. They are crazy smart, I think is how I will introduce them. When it comes to this subject, very much appreciate you guys being here. I know that you're busy. I know that you both travel a lot. I know that you both have your hands in about 1 million different pots at the same time. So the fact that you're both here together, I very much appreciate it, and I think it shows great respect for the work that we're doing here. So I thank you for making the effort it took to get here, because I know it was not easy to make this happen. So with that, turn it over to you guys. If the green light is on in front of you, your microphone is on. We are broadcasting, so for everyone else in the room, you probably want to leave your microphones off. If each of you, when you talk, can introduce yourselves, the people who are watching through the live stream, a lot of times it will be hard for them to know. So if you can introduce yourselves as you move along, that would be great. With that, I'll turn it over to you guys. And again, thanks for being here.
Thank you, Senator. Melanie Forkiller with Choctaw Nation. Thank you all for inviting us here. We do appreciate having some of your time. I bring greetings from Chief Gary Batten and Assistant Chief Jack Austin. We appreciate be able to share some things with you today, and appreciate the large undertaking you have taken up. Healthcare is complicated. We've heard that before, and Indian healthcare even more so. So we hope to be able to share some of that with you today. A wise leader once told me to always begin at the beginning. So that's where I'm going to start today, and that is the foundation for Indian healthcare and how it sort of came to be. going back to the U.S. Constitution, recognizes three sovereigns in this country, the federal government, of course, states as being sovereigns, and Indian tribes as being sovereigns. Tribes predate the United States government. In fact, there are several tribes that had treaties with Great Britain, with other nations that colonized this area before there was United States, and even into the Continental Congress. So these relationships go back a long, long time, especially with tribes on the eastern seaboard. And within the Constitution, in the Commerce Clause, it specifically recognizes the government-to-government relationship between tribes and the federal government. There was an intention that the federal government retain that to themselves in terms of our dealings with on a government-to-government basis. For many, many years, we had treaty making until the late 1800s, and that's where we entered into bilateral agreements where, as you know, most of you probably know, we ceded vast amounts of land. Many of us relocated to here and other areas of the United States away from homelands, and negotiated various things in those treaties and agreements, peace, protection, among those. Also health care was a noted portion of many of these treaties. So that relationship began very early on as a political relationship. So it's a relationship between a government and a government, and that's to be contrasted with race-based relationships or programs that are created around ethnicities or to try to bring up disparities for various race classifications. To draw that distinction is really based on our political status, not a race-based or ethnic status. So again, the federal government retained it as a federal obligation and really was specific that that obligation should not be shifted onto the states. And we'll get into that more as the presentation goes on. The Indian Health Service itself is a federal agency. It's one of the direct health care agencies that the federal government has, along with Medicare, Medicaid, and the VA. So those are the four direct federal health care programs that you'll find in the United States. The Indian Health Service was created in 1955 to shift health care really out of the War Department, which is interesting, into a more, under what was the Public Health Service and now is Health and Human Services. Today we have with us Elizabeth Fowler from the IHS area office here in Oklahoma City. She's representing Rear Admiral Travis Watts, who's the area director there, and we'll talk about the IHS Oklahoma City area quite a bit more. So just to be a little more broad, all federal agencies are responsible for fulfilling the trust responsibility, as we call it, that is owed Native nations based on those old treaties, which carry the full force of the law even today, that in order to make sure that those obligations are fulfilled. So not only IHS is tasked with that, the Bureau of Indian Affairs, but any federal agency that really touches Indian country and interacts with us on a government-to-government basis. So just a bit about who is eligible for Indian Health Services. That's found in 42 CFR Part 136, and I'm going to quickly go through it. Basically, there's two major components. One is being Native, and so that is the first component I'm going to talk about. Primarily, if you are a citizen or a member of a federally recognized tribe, and there are about 560 of those federally recognized tribes in the United States, then you are eligible for Indian Health. If you have an active participation in tribal government, you reside on what's considered Indian country, trust or restricted lands, you can be considered eligible for Indian Health. And then the last category there, in terms of Indians, and I'm gonna interchange Indians, Native Americans, and that sort of thing today. But if you can prove Indian descent, meaning you have a CDIB, a certificate of degree of Indian blood, or you have a birth certificate that shows you're a descendant from a citizen of a federally recognized tribe, then you're also eligible for Indian Health. So the second component I'm going to talk about for Indian health eligibility are eligible non-Indians, this is a lesser-known area of eligibility. First of all, children. So if they're minor children in the household, they're either natural or adopted. They could be stepchildren, foster children, legal wards, or orphans of eligible Indian. They're eligible for Indian health care. Spouses can be made eligible upon decision by the tribal government. And if they are made eligible, they're made eligible as a class. So some tribes have elected to do that in Oklahoma, some have not. A non-Indian woman who's pregnant with an eligible Indian's child, and that coverage begins for prenatal through the delivery and postpartum. So it is a limited eligibility for that period of time, but non-Indian women pregnant with Indian children. And then finally, non-Indian members of an Indian household, if there's a matter of a public health hazard or contagious disease that needs to be treated in an entire household, then those persons can also be eligible for that period of time that's being done. So just to profile a little bit about the Indian healthcare system in Oklahoma, we're going to drill down a little bit. The Indian Health Service is made up of 12 area offices, as we call them, one of which is the Oklahoma City area office. We have by far the largest active users, as we call them. It would be active patient population. That would be a patient that we've seen at least once in the last 3 years. As you'll see in the chart, Oklahoma is over 376,000 active patients, and that is over 130,000 more than the next area office size. So we are by far the largest area office. It technically consists of not only Oklahoma tribes and members, but also Texas and Kansas. However, Oklahoma by far has the largest population as well as the number of tribes. There are 39 tribal nations in the state of Oklahoma, and in terms of who provides these services or administers them, they're not only administered directly by Indian Health Service, so some facilities are administered directly by IHS, but also tribes administer these facilities, as well as we have 2 urban programs, one in Oklahoma City and one in Tulsa. I think I need to back up one. That kind of got reversed. Okay, so with regard to how the IHS is funded, I'm going to talk about relative funding among the area offices. And when we look at the overall, what we call level of need funded, Oklahoma is at the bottom of the 12 area offices. That is based on a benchmark that we use of the national health care expenditure for an average U.S. citizen in this country, and also includes IHS appropriations, and also it accounts for any third-party reimbursements that we get. And we'll talk more about third-party reimbursements later. It is, so the per capita spending in 2017 for IHS, and this is a national average, was a little over $4,000. It's less in Oklahoma, compared to $9,700 for a U.S. citizen on average. So Oklahoma area, once we made those calculations and account for all those revenue streams, we're funded at 39% level of need funded. So meaning if we needed $1, we're getting 39 cents of it. And so that accounts for, as I said, third-party reimbursements. So to fully fund IHS nationally would actually take upwards of $37 billion, and presently federal appropriations are about $5.8 billion. So that tells you how far behind we truly are in meeting that federal trust obligation we talked about. So you'll see the 12 areas here, Oklahoma and Bemidji being the lowest on the level of need funded, and the highest level of need funded area, even only being at 62% level of need. So that sort of illustrates where we are in terms of overall resources. So this map shows where our facilities lie, and you will see, I don't know if I can do this. Okay, yeah. We've got the blue illustrates where the hospitals are, and you'll see we have all of our hospitals are located in rural areas. We have none in a metro area. There are 8 total hospitals in Indian health system in Oklahoma, and many, many outpatient facilities. So all of the other dots there represent outpatient facilities. The red dots represent what is IHS operated, green dots tribally operated, and then the yellow squares are the 2 urban outpatient facilities. So as you can see from this map, the IHS facilities that we have in Oklahoma are primarily concentrated in certain areas of the state. They're going to be located primarily on the east and southeast portions of the state of Oklahoma, and that's because of a lot of historic reasons, really. Some of the larger tribes were relocated to those areas of the state, therefore largest patient population, therefore the more facilities that we have in those areas. As I said, 8 hospitals total and 53 outpatient health centers or clinics. They vary greatly in terms of the scope of services they have at those facilities and the size. So it may be a 1 provider clinic, with a nurse, or it may be 150 employees at a larger health center with multiple primary care providers, pediatrics, and a whole array of services. So the scope of services is also very varied among all of those facilities. With those serving a user population of 320,000 of the 375 in that swath of area, and I've got it marked off for you in the next map. That amounts to about 3.2 million outpatient visits annually, and really outpatient are the services that we provide directly, and we'll again get more into that. Overall, in 2017, Oklahoma as a state had a population of 3.75 million, and the American Indian population within Oklahoma is a little over 500,000 of those, so about 14% of the population. In contrast, if you look at the numbers of uninsured, we represent less than 10% of the uninsured population, and we can speculate why that is. I do know many of the tribes make very concerted efforts for enrollment in certain benefits if persons are eligible, as well as if they can attain insurance at a very low cost. We try to encourage them to do that and get coverage. So although there's over 375,000 patients that we've seen at least once in 3 years, we don't always see them every year. We also don't see, obviously, all of the Native Americans that live in Oklahoma. So we'll get more into scope of services and how many of those services people actually do receive from us. So as I said, as I promised, this map shows where the majority of the facilities and what we call the active patient population is. So as you can see, pretty much you can get within a 30-minute, 40-minute driving radius of an outpatient facility on the eastern side of the state. Once you get west of Oklahoma City and north, that distance becomes much, much farther. So access to care, in other words, the only hospital on that side, as you can see, is in the extreme southwest. That's Lawton. So if you needed any kind of inpatient care, it's probably going to be purchased for you at a closer facility rather than you driving across the state and trying to access that service. So that makes access to care also very varied based on where you live. So just to run through pretty much what we provide directly. So this would be services that we would provide physically in a facility of ours, either an outpatient facility or an inpatient facility. We do a lot of preventive services. It's something Indian Health has always done. Tobacco cessation, public health, diabetes prevention and treatment, health promotion, disease prevention, nutrition services, and a full array of preventive services. Primary care, this is really what we do a lot of in terms of direct care. So that means, you're on one-on-one with a provider, you have a primary care provider, and any ancillary services. So whether there's radiology, pharmacy, lab, that's tied to that provider visit. And we also do, as I said, we have 8 total hospitals. Choctaw Nation has one. None are tertiary care centers, so we don't have specialty care in those hospitals. In fact, you would probably compare them more to community hospitals than you would the hospitals you'll see in the metro areas or those hospital systems. They're in remote areas. They're not in, some are in very remote areas. Tallahena has no other providers other than us, the Choctaw Nation in Tallahena in extreme southeast. And some don't even have intense ICU units. So, for example, our hospital does not have ICU, so that means we have to transport a lot of patients if they're needing that service outside of Tallahena, and we'll usually fly them out, so that comes at a pretty great expense. So limitations on what we provide directly. There are limitations. Even though the facilities are there, they have an open door policy if you're eligible. There can be long waiting times to receive services just because of the vast volume of patients we're trying to see. As I said, the scope of services in every facility is different. So you may have x-ray available at one facility, but you may not have it available in a small facility. So if you need an x-ray, you may have to travel to another available facility that does not have waiting for you to get that x-ray done. Distance to the facility, we've talked about that. It's all relative based on where you live. And we share the challenge of recruiting and retaining providers in rural Oklahoma. Pretty much all of our facilities are rural. It's a big effort for us, and something you have to very sustain and keep a lot of effort on to make sure that we have enough providers so that we can provide the services that we're intending to offer at each facility. So with that, I'd like to hand it off to my colleague here, Melissa Gower, who's going to talk about the things we don't provide in a facility.
So good morning, I'm Melissa Gower. I'm the Senior Advisor Policy Analyst at Chickasaw Nation. Greetings, thank you so much for allowing us this opportunity. I've worked in Indian healthcare for, I was going to tell you exactly how many years, but then you'd kind of know how old I am, so. Anyway, let's just say a long time, okay? And I've been an administrator of Indian healthcare services, worked really in all capacities almost, just working my way through the system. So it's my privilege and honor to do this, and hopefully we will leave you with more information than you came with. That's our goal. So Melanie did a great job talking about our facilities, who can go to our facilities, what we offer in our facilities, and where they're located, and the foundation of why there's a federal obligation for Indian health care. So has anyone ever heard of purchased and referred care? Okay, raise your hand. I know. Surely your physician has referred you out somewhere, right, for a specialty care, right? So that's what I'm talking about. So in the Indian healthcare system, I'm just explaining my terminology. So that's called purchased and referred care. It's really kind of backwards. It's really referred and then maybe purchased care. So we all get referrals, right? And then it depends on your, available resources and all those kinds of things, whether or not you actually get that referred care. So that is what we call in the Indian health system, PRC, for purchase and referred care, okay? So if I slip up, I'm going to try not to use acronyms, because when we work in a world for so long, we talk in acronyms, right? So I'm going to try really hard not to do that. But if I slip up, you'll know what PRC is. It's purchase and referred care. So it's really interesting. You saw the chart about our funding, and that Oklahoma actually is last in the amount of funding we receive from the federal government for our healthcare system, right? We're the last one. We're the last of the 12 areas. Well, our PRC funds to purchase care, guess what? We're also the last. We rank 12 out of the 12. I know that sounds familiar to some of you on other things where we're kind of at the bottom of the totem pole, right? We don't want to be there, but we work really hard to try to ensure there's some equality in that. Melanie and I spend the majority of our time advocating trying to ensure that we get additional funds for these categories. But right now, we're 12 of the 12 in purchase and referred care. So of course, that limits the amount of money that we're able to actually purchase for. And I'm going to get into actual money in a minute. But because of that, we actually are not able to purchase very much care. So we refer because our physicians are under the same medical responsibility as all physicians, in that they are responsible to refer people out for additional, upper level care if they feel that care is needed and they can't provide it. But just being referred out and having a referral does not mean that that service is going to be paid by wherever is referring you from. And that's a real misnomer in Oklahoma. I mean, I have tribal citizens all the time saying, well, I had a referral. Yeah, but it wasn't an approved referral for purchase, right? It was just a referral. That's a medical obligation to give you a referral and tell you what you need. But whether you're able to get that and whether we're paying for it is a whole different story. That's a second, and that's why we break it out between referred and purchased, okay? So because of that, we have to prioritize all of our referrals, and those really are limited to life and limb threatening issues. Okay, you're going to hear that several times, life and limb threatening. And in the Indian healthcare world, we prioritize care by levels. We say level 1 is life and limb, and then you got level 2, level 3. Right now, we're barely paying for the majority of level 1, which is life and limb threatening. That's it. Outside of that, you're not going to get that paid for through the Indian healthcare system. You're going to be on your own. So the volume, and I just pulled these numbers from 2017. If I had more time, I could probably get 2018. But we had about 75,000 referrals in 2017 in Oklahoma, 75,000 that were either denied or what we might call deferred, which basically means denied. It means we'll defer it till next quarter and see if we get more money, right? But that hardly ever happens. So they're pretty much denied. So we had about 75,000 cases, referrals that were actually denied. And then, people are on their own to see if they can get that referred care somehow. So because we're not able to really refer and pay for people going to specialty care, and we're talking about, special care that has touched one of us individually at least in our lifetime, if not multiple times in our lifetime. Cardiologist. I would say there's a lot of us in this room that's probably needed a cardiologist at some point in time. We have oncologist. Unfortunately, that is something that touches all of our lives and we need to go to. And we don't really pay for that because it is not life or limb threatening at the moment. You may say, well, if I think I have cancer, that's pretty threatening. It is, but it's not at that moment, right? It might be 6 months down the road when you get near the end of life period, it might become threatening. But at that moment, it's not. So it's not classified as life-threatening. So what happens is that lack of appropriations then leaves many without any access to specialty care. As Melanie said, we do provide primary health care in our facilities, and we do a really good job. We're probably one of the best providers of primary health care because that's what we do all day, every day. We do primary health care. So we follow patients, we do great care coordination, all of those kinds of things. But once you go outside our doors and you need care outside our doors, you may be in trouble. And you're going to need some resource to help pay for that. So I went over a little bit of the specialty and tertiary care that are routinely denied. I said cardiology, cancer, neurology, nephrology, which we use a lot because we have a large diabetic population, right? Orthopedics, oh my gosh, I can't tell you how many orthopedics we deny. And, you know, so many of us have, especially later in our lives, right? We're starting to get orthopedic issues. Our knees are hurting, our backs are hurting, or, you know, whatever, shoulders are hurting because, probably because I hauled too many bales of hay when I was a kid, and my dad worked me too hard on the farm, but, you know, whatever reason. So where do we purchase these services from? Well, we purchase them from all different aspects of the healthcare sector. We purchase a lot from the local doctors and local rural community hospitals that are in our rural communities so that our patients can get there easily. We purchase some of those there. As Melanie said, they don't have an intensive care unit, so they can purchase that from a local community hospital. We also use and purchase a lot of services from large healthcare systems. You know, the Integris, the St. John's, the Hillcrest, the St. Francis, Mercy, all of those big, large health systems, we purchase, OU, we purchase a lot from. We purchase a lot of services from the private sector and those in various different places. In fact, in Oklahoma, just to put some money to it, we purchase about $121 million worth of private health care. That's how much money the Indian healthcare facilities are putting into the private healthcare sector. $121 million a year. That's a lot of money, but it still is not enough to cover, you know, all of our referred needs. But when you think it's a lot of money, and when I first saw this figure, I thought, it can't be 121 million. We ought to be able to pay for everything. Because I still think, you know, to me, millions is a lot of money, right? But then you start dividing it by our patients, the 375,000. Guess what? $321 per patient per year. How many has ever even hardly walked in a healthcare doctor's office for $300? I mean, I can't even think of hardly a lab test or an x-ray or anything you can get for $300 a person per year. It just isn't going to happen. But when you look at it that way, then you can see how rationed it is, because it is a very low amount. $321 per year is what we have in Oklahoma per person to buy needed specialty and tertiary care. But despite, so basically I talked about the 4 levels of priorities that we have, right? Your life and limb, your number 1, and then your number 2. And as I said, we really are only expected to be able to really pay for level 1, and sometimes not all of that. And that's really emergent or just acutely urgent care services. So let's talk about what level 1 does not include, that is hardly ever paid for in the Indian health world. So any kind of diagnostic procedure that we don't have the equipment to provide in our facilities, that's usually a level 2. So that doesn't get paid for. Any kind of a treatment of acute conditions, care for chronic maintenance or systematic relief, primary and secondary care, which really has a significant impact on morbidity or mortality. Chronic tertiary and extended care. You know, we have a lot of things like skilled nursing, rehab units that are being used these days, very fruitful, and is doing wonders for patients. Those things are not covered. That's not life or limb threatening. Those are really level 2. And you might think, oh my gosh, she really sounds cold when she talks about this. But, you know, when you're in the business of rationing healthcare day after day for 30 years, it's a sad situation. But I'm just telling you the realities of the Indian healthcare system. So we don't pay for prosthetics. You can imagine with the high diabetic population, the need for prosthetics in our population. Therapeutic services, orthopedics, durable medical equipment, long-term care, restorative, dental. We pretty much just have fillings and cleanings in our dental clinics in our facilities. And I just stuck these in here because I could actually put in 3 examples of my own family because I am a citizen of the Cherokee Nation and I do utilize the Indian healthcare system and always have. That's where I was born, that's where I was raised up, and that's where I still go today. And I could probably do that, but I just wanted to give you a couple of real life experiences here. So we had this patient that was actually seen for back pain, don't have an MRI in-house, so we referred that patient out to have an MRI. Well, in the Indian healthcare system, if you don't have resources, and that's denied because that's a specialty diagnostic test, right? So we can send them because there might be an Indian health facility that has that machine. So say, for example, if we were at Chickasaw Nation and sent that person out, and at Lawton they had an MRI machine, we could send them over there because we can go to any facility, and they could get that. Well, that we send them over there, and the waiting list to get an MRI was 13 months. So they came back to the doctor and said, I really want this. My back is just killing me. I really got to have something done. So they give them a referral to a local MRI place that had an MRI, send them out, and the patient, it was denied because we don't have money to pay for it. The patient actually ended up paying for it themselves, and it turned out to be malignant. And it was a sad story. And I don't mean to, I know it's early in the morning to start talking about sad cases, but I'm just kind of giving you some real life experiences here about what really happens. And then on just a couple more, the second one was a 62-year-old patient. 62, we know that's 3 years short of Medicare, right? So we got a problem already here, you can tell. And we all know our knees are the first to go. So both of her knees are bone on bone, needs knee replacement for both of those, won't have Medicare for 3 years. And there's just no funds to pay for it. And this grandmother was raising her grandchildren. So she's still stuck with, having severe pain and problems because she just didn't have resources now to be able to go get this procedure done. That would make her quality and her grandchildren's quality of life so much better. Number 3, a 44-year-old female was diagnosed with multiple sclerosis, had been getting treatment for it for 20 years. Part of that treatment was oral steroid medications, caused her hip joints to need to be replaced. No funds available for hip replacement. Actually, she was a nurse, and very productive nurse, worked in nursing for years. Now is actually in a wheelchair because she doesn't have resources to be able to get the hip replacement done. Okay, on to a little more, maybe not so sad, but I don't know, it's pretty sad overall. So I've heard this question a lot, and I have had, I don't know how many hundreds of people when I worked in the operations of Indian healthcare system. Well, I've got you guys in this facility, why do I need health insurance? Because we really encourage our patients to take out health insurance if they have an avenue to do that, through their work, through the marketplace, through the chamber, there's some that can get through small businesses, different avenues. We really encourage, and then sometimes the tribe even does sponsorship programs where we help pay those premiums for those people to get that. But I've heard this question many times, why do American Indians need insurance? Well, while we are very efficient, okay, with the 39% of federal funding we get, and that funding is Congress appropriated, Medicare, Medicaid, and private insurance. It includes all of those revenue streams. While we're very efficient with that, very efficient. I mean, go to any of our healthcare systems and you'll see that we are very efficient with that. The Chickasaw Nation, we have one of the top premier healthcare systems. It's still a primary care, but we have one of the top systems, and, it's just a great system. So most of the tribal systems are. As Melanie said, we're located in concentrated areas. Distance to the facilities prevents a lot of access to care. Wait times can be a problem because, as you saw, we have the largest user population of anywhere in the U.S. It's very similar. Why we need health insurance is very similar to the reasons that other folks need health insurance. Folks that use the community health centers, FQHCs, free clinics offered by the university or otherwise, those people need health insurance too. Just because they have some access to primary health care does not mean they don't need health insurance. So it's for those same reasons that everyone else needs healthcare insurance is why we need health coverage. And when I say insurance, I mean coverage of some sort, right? So even with the limited access, there's still millions in uncompensated care going on. So why do patients choose our systems? Well, I think there's lots of reasons. I just told you why I choose it, because I was born there. I know the people that work there. It's in my community. I still go there, and I have health insurance. I have resources, but I use the system because that's what I'm used to using. That's who I know. We provide culturally competent care for a lot of patients that use our system. This is very important. We have close proximity to health facilities, access to care, talked about familiarity with and a sense of belonging with our staff. My niece works at so-and-so, my sister-in-law works at so-and-so. We're all just, tribal communities where we all work together and play together and live together. And then just continuous care. My physician, where I go at Cherokee Nation, Three Rivers Health Center, she coordinates all my care. Even if I'm going outside and paying for it or getting it through my insurance, she coordinates that care. She's my primary care physician, my PCP. And so hopefully that shed a little light about the purchased and referred care at our Indian healthcare facilities and why we need health insurance. And now I'm going to turn it back to Melanie. Thank you.
Thank you, Melanie Forkiller. And now I just want to dig in a little deeper on third-party reimbursements. We've covered that just a little bit in terms of that we're collecting third-party reimbursements, and we use that to supplement federal appropriations. And being funded at 39%, that accounts for all of those reimbursements. So as Melissa said, private insurance, Medicare, Medicaid. Of those three funding streams, by far, Medicaid is the most important third-party reimbursement into our system. So it represents the largest amount at 13% of those third-party reimbursements. And that's on average. I would say in Choctaw Nation in southeast Oklahoma, we've got very high poverty areas, and it varies within the Choctaw Nation in 10 counties, but some of those counties are very, very high Medicaid population because of the poverty level of those communities. Because the IHS appropriation is so low, we were authorized to bill and collect for those reimbursements. In fact, specifically to Medicaid and Medicare, Congress authorized that in 1976, and they amended the Social Security Act in order to do so that those reimbursements could come in and supplement the deficient Indian health appropriation. At the same time that they authorized us to bill and collect Medicaid, they also ensured that that would be reimbursed at 100% Federal Assistance Matching Program, or FMAP. And that means that the state would not be responsible for matching those services that are provided either in or through, even via referral and payment from our facilities. And that is because Medicaid is a state-administered program by law, the federal government did not want to shift that burden or obligation onto states by having them match for those services. So it's 100% matched. So Congress also said at the same time that this was intended to, specifically to supplement the Indian Health appropriation. So they recognized that Indian Health appropriations at $5.8 billion were even close to fulfilling their obligations, and so these were intended as to supplement those funds. And as you can see, at 39%, we're still not even close, but we're a little bit farther because of those third-party reimbursements. So therefore, any care provided in, directly by, or through to purchased and referred care is 100% matched and has been since 1976. So just very, very broadly, in terms of currently in the Medicaid program, there are over 133,000 beneficiaries who are American Indian Alaska Native, and 73% of them are children. And I think that's a higher percentage than in the general Medicaid population, but I'm not really sure about that. I think it's typically 60-something% in the general population. The existing FMAP that the state collects, that they don't have to match, let's say. So the savings to the state for the 100% FMAP with our current level of services amounts to $88 million on an annual basis. So that's a significant amount of savings that the state doesn't have to spend on health care, but that we're able to deliver in and through our facilities. And then even despite these resources, Oklahoma itself, while it has a high uninsured or uncovered population in general, it has the highest uninsured or uncovered Native population. So we are the last remaining state. Alaska just got coverage for a number of their folks, and I think they were the next highest. So we are the highest Native population that does not have a third payer resource. So that kind of wraps our first overall Indian Health overview, and we wanted to turn it over to the chair.
Thank you guys very much. Representative Lawson for a question.
Thank you, Mr. Chairman. Of the 12 regions that we have, you said that we were 12th in as far as funding goes, and I'm hoping you can just kind of elaborate on really that formula. I know that there is some Medicaid, Medicare match to that, but looking at the table you had, by far we've got the largest Indian population of the 12 regions, and I'm just curious how the math equates that we're getting the least amount of funding on that.
I think, I will first say there's no hard and fast reason. It is my experience that those came from historical allocations by Indian Health Service, so it really depended. It was once entirely run by IHS, so the entire system. So all of the facilities that were created as federal facilities, and so the allocations that came to this area versus that are really a matter of history over the decades of Indian Health. So I will say that one thing that has sort of happened is that we obviously have a large patient population. That population grows at a faster rate than any other IHS area. We do not get money specifically for population growth on a reliable basis from the federal government, so it doesn't keep up with population and costs, and so that just continues to make that divide even further as the years go by, because the population rises, we don't get population growth money to accommodate that, so the gap keeps getting wider.
Senator Haste.
Thank you, Mr. Chairman. Kind of following up a little bit on Representative Lawson's question is the first part of my questioning. So these are all federal dollars, correct? That are coming in. This has nothing to do with the state right now as far as that 39%. That's all related to federal dollars, or is there something else there?
It's federal, it's appropriations by Congress, so federal appropriations by Congress, Medicare reimbursements because we bill, Medicaid reimbursements, and insurance reimbursements. That's our 4 revenue streams.
Okay, follow up?
Follow up.
So with that, so part of this is working to get, let's just say, our fair share coming through Indian Health Services, which means working through Congress. Is that correct?
Yes, I think that's certainly one issue, and as Melissa said, that's pretty much our job, is advocacy nationally to not only try to achieve more parity among the areas with the existing appropriations, but also advocating for additional appropriations, because as you can see, it's clear we're not there. I think the other thing that's a good thing to take away from this, even though the state doesn't have a participation in the Medicaid reimbursements that we receive, it's a pass-through essentially, services providing by and through, should anything change in the Medicaid system, should be considered, because that's a whole category of services that the state doesn't have to pay for. So as you all continue your deliberations.
Okay. Follow up.
Before Senator Haste has his follow-up, with the construction going on right outside the door, there's a door to my left, your right, that takes you into a kitchen and then can get you back out in the hallway. It would really reduce the noise in here if you guys would use that side door when you're coming in and out, and I think that'll help our ability to hear with all the construction noise. So with that, Senator Haste, follow up.
Thank you, Mr. Chairman. So obviously by this, part of our mission should be working to get our rightful share of the federal dollars to begin with, not set everything else aside. That is an important part of this and would be very beneficial.
It is.
Okay.
And we do that daily.
It is, and continuing to partner and further the partnership that we have with, in particular, Medicaid, and I only bring up Medicaid often because it's state administered, and so we have to partner in order to further that, to supplement in cases where the appropriation doesn't make it.
Okay.
Follow up?
Thank you, Mr. Chairman. As I was listening to some of the challenges that you have, and which are not unlike, the tribe's not unlike other areas of rural Oklahoma, where, we're dealing with shortages of specialists and all that kind of stuff. So part of that is maximizing the primary care physicians to be able to do some of this. So I'm just curious, has there been any consideration looking at programs like Project Echo and things like that to help, help primary care physicians to operate at the top of their license?
Absolutely. I would say that the primary care physicians that work in Indian healthcare facilities are some of the physicians in the state that do operate at the top of their license. And the reason they do is because their patient panel are folks like the 3 examples I gave you that can't be referred out and get the care. So they end up back in the physician's office needing some sort of relief. So that physician knows if they can't get their care paid for outside, they're going to have to do everything they can for that patient because they're still their PCP and they're still going to have to take care of them. So yes, we've been doing that for years. Absolutely.
Okay. Follow up. Thank you, Mr. Chairman. So along with that, obviously primary care physicians are a critical part of this whole thing. So now that there's a med school, tribal med school in Tahlequah, my assumption is that is going to benefit and help get overall better care over time because that's now in place. Is that?
So I think the short answer, of course, would be yes. Any medical school we get in rural Oklahoma is going to be very beneficial, right, for all of rural Oklahoma. I can tell you that the tribes for years have tried to address this problem. And one such way is that both the Choctaw Nation and the Chickasaw Nation have current medical residency programs within our facilities in partner with OSU. The Choctaw Nation has 12 residents currently, and we have 8 residents currently, and we'll pick up 4 more. So we already have full operating medical residencies in the state of Oklahoma to try to combat some of that, because it's proven that if people, go into the rural communities for residencies, lots of times they'll end up staying in that community. So we figured that out long ago, and we've been doing that for a long time. Now, we have to fight continually to try to get funds to help us do those residency programs, because they are expensive, right? But for sure, the medical school that the Cherokee Nation is doing is another great partnership opportunity that's been capitalized on. And we're all very excited about that. And, that will just bring more value to the primary care issues in rural Oklahoma.
Okay. Last follow-up.
One more.
Yeah. Thank you, Mr. Chairman. Yeah, and a comment first. Even though the med school is in Tahlequah and the Cherokee Nation's working with this, it is open for all tribal nations.
Yes.
So my last question is kind of just a point of information. You mentioned in your opening when you started, there are 39 tribal nations. Okay, I'm just trying to understand that a little bit, because there's always the conversation of 68 or 69 tribes. So what's the difference?
38 or 39. No, yeah, he's talking about there's difference. Some people say there's 38 and some say there's 39.
Well, the number associated with 39 would be federally recognized tribes. There may be other tribal entities in the state that someone might count that adds to that number, but when you look at the federal recognition list, there are 39.
Okay.
Uno Moss.
Yeah. Thank you, Mr. Okay, so from your, because, the number I've been hearing, unless I've been dreaming this, has always been around 68, 69. So you say the actual recognized number is 39.
Federally recognized tribes is 39 in Oklahoma, and you can go to the Bureau of Indian Affairs website and they have a list of tribes that's been federally recognized. I have never heard 68 or 69, but we're assuming that could include maybe state recognized tribes or tribal organizations or entities of some sort. That's really my best answer.
Okay, well, thank you very much. And sometimes we hear stuff here, so just thank you.
All right, I know that Representative Lawson has to leave for another meeting, so kind of let you cut in line and ask another question.
Thank you, Mr. Chairman. I'm going to go back a little bit to this funding formula, and just hoping to gain a little context historically, because I would assume that this has been talked about at least at the congressional level. And is it something they're just having a hard time gaining consensus? Is it, politics surely plays a part in it. Is it maybe the regions that are getting the higher appropriations are just better at hanging on to that? I mean, what's the, in your opinion, what is the biggest issue that's keeping parity in
Okay,
that
so
funding?
I guess Melanie took a shot at it. I'll try to take a shot at it and see if we can do something. But, she's correct. The funding for Indian Health Service is historical. Before me, and when you ask people in high-level positions why there's the disparity, it just started out that way. And I don't know exactly all the reasons why, but it was historical. So we have attempted over the 30 years I've been in Indian healthcare to try to bring some equality to that. So really there are 2 primary factors, one, I think. And one of those is the rate of growth, population growth for American Indians. Oklahoma has one of the highest population growth. So our user numbers are going up, right? At a much higher rate than the other areas are. And then the other one is that we have tried over the years to get formulas for any other new pots of money or whatever to be based on population. And we've been successful at doing that. I mean, you think it's bad at 39. I remember when it was 29. So we've been pretty successful in trying to get new pots of monies and formulas, a population put into a formula, not the formula, but as a component, right? Because that's what benefits Oklahoma. But, you know, when we're two from Oklahoma in the room with the other tribal people from all the other states that have small populations, you know, they don't want population in the formula because it's going to hurt them. So I just want you to give you a perspective of what we're dealing with. But also Congress recognized that there was this disparity, and they created a fund called the Indian Healthcare Improvement Fund, and that was a specially appropriated funding that was a formula that was intended to equalize some of these percentages, okay? So for example, in 2018, Congress put $70 million in this fund and said, give it to the lowest funded health systems, Indian health systems. So we have a formula, we applied the formula. Oklahoma got 42 million out of the 70 million. That's how, you know, we're trying to equalize. So Congress has made efforts to try to help with that. The problem is you get, when you start going into the congressman's office in DC on appropriations, is budget caps. I'm sure y'all understand that, you know, they only have so much appropriation for, and IHS, even though organizationally we're under DHHS federally, appropriation-wise, we're in the Interior Approps bill. So, you know, when Congressman Cole was the chair of that committee, we only have so much money. So if we take from here and put in here, we're going to have to take, you know, that kind of thing. And so, I mean, there are many, many efforts over the years to try to equalize that. Does that help? I just can't give you one reason why historically it was done that way. I don't know.
Chairman McIntyre.
Thank you, Mr. Chairman. Thank you both for being here. I have three kind of compound questions, and so I'll try to give them to you. There's been a lot of talk in this committee about American Indians not being, or being in that uninsured rate in the state. So I was curious if you guys had or know of a percentage of American Indians with private health insurance. If you don't know what that overall percentage is, do you know by your tribe? And if you don't know that, then what percentage of your pay mix is private health care insurance?
Those are three great questions. The first one I don't know the answer to. Maybe could find it somewhere. The second one I don't know the answer to. The third one is going to be different per tribe, right? So if I had my phone with me, I could probably look that up really quickly. But I think the Chickasaw Nation Health Department is, do you know what y'all's is? I hate to give a number because I don't know.
You can get back to us.
Okay. Can I do that? And I can look at break and tell you what that is probably.
Okay, and we'll share that information
Okay.
with the members. Follow up?
I'm going to say it's in low teens.
Okay. So let's talk about your referred care. And let's just take Medicaid as what we're looking at, the payment method. So how do those Medicaid payments work on a referral basis? So we know that the tribes are reimbursed 100% of FMAP. So if you refer that care out, what does the doctor you referred to, what do they get paid? Do you guys take a percentage of the FMAP, or does the doctor get paid at all? That's what I'm trying to figure out.
Sure.
Okay, so purchased and referred care, when we authorize for payment, meaning we're actually going to purchase the care, and that person's Medicaid beneficiary, we require the outside provider to bill all third parties before they bill us. We would be the payer of last resort. So if they have Medicaid, they'd be required to bill Medicaid first before they bill us any remainder, if there is one, based on our contracts that we negotiate. What they get paid is the same rate that they would get paid for any other patient if they're paid by Medicaid. The difference is it is 100% matched. So that means the Medicaid agency pays the bill to that provider. Then they apply to CMS, Centers for Medicaid and Medicare Services, for 100% match for that payment they've made to that provider. So actually the match is made to the state and doesn't affect the provider payment one way or the other.
Follow up.
This is, okay, so just to make sure I understand, basically, doctor gets paid what he would get, he or she gets paid for any Medicaid patient. However, the state ends up getting that that gap that's 90 or whatever, or 12% more or whatever. Is that correct?
That's precisely right, yes.
Oh, okay. I have one more follow-up.
Follow up.
Okay, you cite 48,756 cases that you guys have denied because of financial constraints on things that are not life and limb. So is there anything out there, I mean, I'm sure that you guys don't like doing that. I mean, that's, it's care rationing. So is there anything that can be done to alleviate that?
I guess I can take a quick stab and then let Melissa fill in any gaps, but we try to find alternate resources for every patient that walks through our doors. So in particular, when they need specialty care, now for primary care, it's one thing, we could get a reimbursement to help build our capacity, but especially when we're trying to get outside care that we may not authorize for payment, we're trying to find every and all resources, even any donations types of resources. Are they eligible for the marketplace for a lesser amount, a small amount to purchase insurance that would get them covered so that at least they could seek this care? And, have they explored all of their opportunities, whether it be VA, whether it be, other opportunities to receive the care. And then in addition to that, another way we're trying to alleviate it, I think, is to build as much internal capacity as we can to take them off the referred list and make it an in-house service. So in those cases where we can build our capacity, for instance, in Durant, in our new facility, we are now doing some levels of outpatient surgery in that outpatient facility, and that is along with the MRI, trying to avoid having to purchase that care on the outside when we can build it in-house. We can only do that on a limited basis because of funding, but where it makes sense and we would spend less to build that capacity in-house, we try to do that.
Follow up.
This is my last question. I didn't intend to ask it, but I think it's important that we know who these people are. I mean, are these people without any insurance at all? Because obviously they could be paid, right? I mean, their care, if they had private insurance, they would not be denied. So these people who are being denied, what do they, I mean, does that make sense? Are you getting what I'm talking about?
So I think it's two things. One is it's uninsured, and two, it's underinsured. That's my simple answer.
Okay.
Senator Stanislavski.
Thank you, Mr. Chairman. So, following along the line of payments, federally qualified health centers charge patients on a sliding scale. Are you all able to charge your patients at all?
I guess I'll start with Indian Health Service. Indian Health Service is not allowed to charge patients. Tribes could charge patients if they so desired. I think various tribes have thought about small amounts of co-pays, that sort of thing. I've not heard of one that's been implemented that way. I think we finally have determined it became more of a barrier to care than it became increasing access to care. And we want those patients to follow through with their care plan and their treatment plan and not avoid an appointment because they've got a copay.
Okay. Well, the reason for that is just simply if you're having to deny or defer so many patients, if you at least have some type of copay that can extend the amount of care that you can give. So I understand it might be a barrier to some, but that was the reason behind that. So the actual follow-up is, you had mentioned the 4 funding sources, but you did not mention how much the tribes actually allocate, which I know would be different per tribe, to put into their health systems as well, because I'm sure they're allocating some dollars as well, whether it's through helping with facility funds or helping with some type of care. Do you have any idea how much, just say Choctaw or Chickasaw, any of the tribes, how much they may actually put in?
And I think, you know, the key point you made is that it's going to vary tribe by tribe, and it does quite greatly. I think from our experience, I've been working in this for almost 30 years also. I guess I could just say the number of years. And my experience has been purchase and refer care is one area that tribes will supplement because the care only goes so far, as you've already seen, and still we're at level 1, and that's even with supplementing. Another common area that I see tribes really getting into with their own dollars is trying to go upstream to those certain level of services that IHS does not fund, and that would be more preventive care, whether it be wellness centers, going upstream to public health and developing public health policy, working with schools, et cetera, to make the environment for public health the easy choice. And those aren't federally funded services. So if we're going to try to get upstream, tribes have been focusing some of their supplements on areas like that as well.
Okay.
So just one quick follow-up on that. The other area I would mention is construction. You know, building new facilities. We don't get money from the federal government to do that. So almost all of that is done through tribal resources.
Okay.
Senator McCourtney, I have an answer to your question, or to Representative McIntyre, who's not in here at the moment, but if you could relay this to him.
Absolutely.
At the Chickasaw Nation, 62% of our patients have coverage. 30% of that is private insurance.
Okay.
Thank you.
Senator Stanzlowski for a follow-up.
This has been my last one. So the slide previous to the question slide here, the third bullet point said Oklahoma has the largest Native population in the U.S. without a health care resource. I don't understand that. Please define what is a health care resource.
We would mean any third-party resources. So no Medicare, no Medicaid, no private insurance.
So I guess I
Follow-up.
have one more. So I still don't understand that then, because you already stated you get funds from Medicare, Medicaid. What is a health care resource?
That means that patient does not have a resource attached to their patient. So if they were to come to our facility, we've got an amount of appropriations, and we've talked about, well, if you understand.
It means coverage in that sense. Maybe resource is the wrong word. Maybe it's coverage is what
Can you go
it
back
means.
one slide,
Yeah,
please? Third bullet point?
right.
So without you had mentioned another state finally got a resource. What was that resource that they got, and we're the last state to not have a resource? That's what was stated, if I remember correctly. What is that?
Yeah, essentially they have, and Medicaid has been the differing factor among the states, essentially. So there are other states that have higher coverage of Medicaid patients. So we're the last remaining highest number Native population without coverage. Mm-hmm.
Who has the biggest one?
Right. Alaska was they just expanded in a couple years ago.
Are you specifically talking about without Medicaid expansion? Is that what that sentence is?
Well, it's the biggest driving factor, although We have really increased enrollment in the marketplace. So if you look at marketplace enrollment, Oklahoma's advanced farther than any other state in native enrollment in the marketplace. But that's a small number compared to Medicaid, which is a much larger driver.
I believe I'll go to Senator Smalley. I believe he may have an answer to this question.
Melissa, I think what Senator Stanzlowski is talking about, what is the federal definition of a native population that doesn't have an actual resource such as coverage that you're trying to say? While yes, they may actually have a healthcare resource within the tribe, they don't have a secondary like coverage through Medicaid or possibly VA or those kinds of things. So the federal definition is important here when you're trying to understand who qualifies and who does not qualify. Is that correct?
Yes, sir.
All right, thank you. Representative Fugate.
Thank you, Mr. Chairman. And thank you for being here this morning. This has been fascinating. I've got a couple of quick questions that are just kind of general questions and then a couple a little more deep dive. The 377,000 roughly that are serviced through the Oklahoma region includes multiple states. Could you remind me which states beyond Oklahoma those were?
It was Kansas and Texas.
Kansas and Texas.
And just to clarify that, it just covers like a couple of I mean, it's a small portion. I think is there 2 tribes in Kansas? Liz? Is it 2 tribes in Kansas and 2 in Texas? Okay, 3 or 4 in Kansas and 2 in Texas, and they're very small.
Follow up.
Thank you, Mr. Chair. So the preponderance is here in Oklahoma.
Yes.
Okay, so second question then is that, Oklahoma has a significant challenge with substance abuse and mental health. And do tribal services cover those particular areas?
So the most of the Indian health and tribal facilities have some basic mental health and substance abuse services, okay? So again, it's just primary. So it's primarily, assessment, diagnosis, and maybe, depending on what kind of treatment is needed, some medication-assisted treatment. We apply for lots of grants through SAMHSA and other programs. So like we have a medication-assisted treatment program at Chickasaw Nation that we operate. A few of the tribes have some very small inpatient residential facilities for substance abuse, but the demand is so great that it's really just very primary, yes.
Follow up.
Thank you, Mr. Chair. So those kind of additional tribal resources then are some things that the tribes themselves are providing as opposed to the government. So the next question really deals with some things that we heard last week from rural Oklahoma hospitals. And we've heard that when uninsured people receive treatment in those rural hospitals, and presumably that means all hospitals in this state, they're vetted to see if that patient is eligible for Medicaid services. And I think you touched on this, but can you confirm that this is also kind of a standard practice for tribal services?
Absolutely, more than standard. We go to great lengths. We have patient benefit coordinators and advocates in all the departments in our facilities that we try to find resources for that person or coverage for that person.
Follow up.
Thank you, Mr. Chair. Well, then this kind of follows on what Senator Haste was asking about, and I think what Representative McIntyre, and it got me kind of thinking. The tribal nation FMAP is 100%. And so there's been a concern, kind of an overarching concern, that there's an underserved tribal population within the state of Oklahoma that's going to cause an undue burden if Oklahoma chooses to expand Medicaid. But with an FMAP of 100%, does that mean that if we do have a shift in tribal population over to Medicaid, that's not going to affect Oklahoma's cost for Medicaid expansion?
So just a little bit on the 100% FMAP, because maybe there's a confusion. So 100% FMAP is captured only if a service, it's not by who you are as an individual, it's by the facility. So it's only captured if you receive a service in an Indian healthcare facility or through an Indian healthcare facility. And the through is defined as referred. Okay, so all of our services we provide in our facilities are covered at 100% FMAP. All the services that anyone goes to anywhere and receives, if they have a referral from their Indian health facility, is covered at 100% FMAP.
Follow-up.
So then if I understood what you were saying correctly, say I live in far western, northwestern Oklahoma where there's a lack of services, I probably would not be covered then either through direct service or referral. So that would affect us.
Sure. As it will anyone that lives there.
Follow-up.
Okay, and then did I understand where Representative McIntyre was going, that because of the 90-10 split between the state and federal, that the state might actually make 10% off of that Medicaid population that does shift?
If someone is covered under, regardless of whether it's traditional Medicaid or Medicaid expansion, if you receive a service in or through an Indian health facility, it's 100%. It does not drop to 90%. Is that what you're asking?
Follow-up.
The question really was more about the state's requirement to front the $100 million and then get back $900 million on the 9-to-1 match. Because what we get with federal services for our tribal nations, we're getting 100% entirely. So that 10% effectively is something that we don't have to pay. So the state makes 10% off of that population?
That it would be a true statement that it remains at 100%. I'm not sure I can answer, I'm not sure I can say that because I don't really follow exactly what you're saying, but it is true that you would get 100%, yes, if that helps. Sorry.
Follow-up.
Well, I don't think I'm asking it very well, so I'll think about that and maybe catch up with you later.
Okay.
The final question then, the 30% regarding private pay. We've heard in here that roughly 46% of the state of Oklahoma has private pay, and another 5.5% to 6% are through government insurance, folks like us legislators that have that. So roughly 51, 52%. And so that got me thinking, if a tribal member does have private insurance, other than a cultural preference, is there a strong reason for them to visit a tribal hospital?
Well, I think all the reasons I listed. I mean, myself, I have private insurance. I've had private insurance my whole life, you know, because I've been fortunate that I've worked for tribal governments, and tribal governments have great private health insurance for all of their members. And I think that's one of the reasons our private insurance is high in our facilities, is because most of it's, you know, our tribal employees, right? We would provide a lot of private insurance. And I still go there. I've always gone there. I'll continue to go there for primary care. But, you know, I also have some chronic issues and I'm referred out. And I have to drive to Tulsa and I live in Tahlequah. So, you know, it's access. I'm having to drive 65 miles to that additional specialty and tertiary care. So I think it's access to facilities, I think it's transportation, I think it's distance, I think it's, you know, time away from work, I think it's access, I think it's familiarity, I think it's my cousin and my mom and my niece work there, and I know I'm going to get taken care of.
Final follow-up.
Thank you, Mr. Chair. I just wanted to clarify, I didn't mean in any way to take anything away from our tribal services that are being provided. I just was curious why the number might be lower than kind of the standard number across the state. So, thank you.
Thank you.
Just members, so you know, I've closed the queue. We've still got a few left. Representative Newton.
Thank you, Mr. Chairman. Ladies, thank you very much. It's been very informative. I just trying to get a better understanding of the scope of patient population that you're obligated to serve. And in my past history and what little I've known about this, it was generally somebody that was on the roll number per se, but from this information I got on this one sheet, that's not necessarily true. Is that correct?
Well, I'll start with being a member or a citizen of a federally recognized tribe. Each tribe determines its own eligibility criteria for citizenship. So many of them are tied to a historic role and then the descendants from that role. Some have blood quantum requirements, meaning if you're not a minimum blood quantum, you can't be a member or a citizen of that tribe, but you would be a descendant and fall under the other category that I mentioned. So in terms of citizenship, it's all tribally driven, and each tribe has its own law, and it's usually in their constitution that it drives their membership criteria.
Follow-up.
Thank you, Mr. Chairman. So I was on here, if I resided on I would say tribal land or tax exempt land, then you guys are obligated to do my health care services, is that correct?
That is what the eligibility criteria says. I would think that that particular criteria is going to be more common in reservation-based tribes than it is going to be in Oklahoma, because you've got defined borders for a reservation in just about everywhere else except here in California. So you're going to find that criteria is used more frequently in those areas of the country than it is here.
Okay, thank you.
Follow-up.
Thank you, Mr. Chairman. Just one more follow-up. You were talking about the residency program that you had residents going in that. Now, those residents have signed on an obligation to serve with the IHS for a certain number of years after payment for your help on residency? No?
Well, there are a couple of programs. One of them is a loan repayment program that Indian Health Service has, and that is true. You sign up for so many years in order to get loan repayment, and you can serve in either an IHS or a tribal facility and satisfy that obligation. We also participate in the TSET program for provider workforce. They have a loan repayment program that's very similar. If you're going to repay in a rural area of the state, and we compete along with everybody else trying to get those folks assigned to one of our facilities. And then thirdly, the residency program. The residency program, they simply sign up to train with us, and we try to become and show them what a great employer we are. They're not necessarily obligated to stay, but at the end of their residency, we find that 90% of them stay in rural Oklahoma, and 70% of them stay within our system. So for us, it's very, it's not only cost effective, but it's one of the most beneficial recruitment retention tools we have. The other thing I'm gonna pitch is, and I think my CMO would pitch it if he were here, is that it raises the entire quality of the health system, because we have our providers as teachers, so they've got to stay up on the most modern methods, all of the things their students are going to know when they're coming to them as residents, and they're providing that instruction in a classroom setting as well as practicum, and they've got to keep up, and so it raises the level really, it really keeps them on their game and raises the quality of the entire facility.
Thank you.
Representative Ranson.
Thank you, Mr. Chair. Ladies, thank you so much for coming in today. What I have gathered so far from what you have both said is there are a lot of similarities between tribal health and non-tribal health, in the sense that we have an underfunded system. The tribal communities have been going through it longer than our non-tribal communities have. So this life and limb that you brought up, to me, I'm like, this is great. At least we have that. But I'm seeing also that the tribal communities are suffering from a lot of the predeterminants of health that our non-tribals are. And I'm curious, as far as one of the primary outcomes of the predeterminant of health, which is diabetes, would insulin be considered as a life and limb treatment? Could you say that in the microphone, please?
So we For the most part, and I can't speak for every Indian healthcare facility in Oklahoma, right? Because they're all different, and we're all different sizes. But for the most part, the majority of Indian healthcare facilities across the nation have in-house pharmacies. Okay, so in our facilities, we have an in-house pharmacy that we provide basic type medication. And for the most part, insulin is on that formulary and is provided directly by the facility.
Follow up.
Thank you. Okay, but your first answer, when I asked the question, you shook your head no. So where is the but in that answer?
No, I think I shook my head yes.
Oh, sorry.
I'm sorry.
Okay, I misunderstood.
Maybe I was popping my neck.
So insulin is covered through the tribal pharmacy within the system?
For the most part, yes. Again, I can't speak for all 57 health centers because I'm not sure exactly what they have in them, but for the most part, I mean, high majority, up in the 90s, I would say, %, that, and maybe all of them, have in-house pharmacies, and that's on the formulary.
All right, thank you.
Representative Marty, did you have something on the answer to that question?
Yeah, thank you guys. You guys did a great job. I just wanted to ask, and I believe I'm correct, I'd done a rotation for a month out in Tallahena, and just everyone here, they do have very impressive facilities, work hard, counsel every patient that comes through. I ran a Coumadin clinic there, so you guys are doing great work with what you have. But when it comes from the drug pricing, when everyone in this room thinks of insulin, they think of $1,000, $700 to $1,000, where IHS buys it at the 340B prices. And so that $1,000 insulin is going to cost the tribe $5 or less. So, I mean, their pharmacy systems are great, and that's not all tribes I can't speak for, but where I have worked, and I do believe that all the tribes are able to buy at that 340B rate, which is definitely an advantage.
If I may follow up?
Yes.
I just wanted to add that that is true. When a tribe assumes a federal facility, they get federal access to the supply, their contract. So, so we would be able to buy it at the same rate Indian Health Service is able to buy it, which is the federal rate. So it's a great help. VA, you know, it's actually a VA contract that IHS participates in. So, thank you.
Representative Stark, earlier I wasn't sure if you were raising your hand or not, so if you were, then it's your turn.
Thank you, Mr. Chair, and yes, I was. I have just one question. If you were to be at 100% funding, how much would still get referred out because of not being able to accommodate the need of that particular patient?
I'm going to venture out here, and then Melissa can add, but I think it's going to vary depending on the location of our facilities, because I think obviously we would want to build capacity to the extent we can to avoid paying higher rates for referring people out to a private provider potentially. So there are going to be components that we may want to be able to build if we had full funding that would be the most cost effective rather than referring those patients out. In Tallahena, America, are we going to be a tertiary care center? Probably not. It just doesn't make good sense to spend the money in that manner. So we would probably still be referring a lot of care, probably less care, but we're never going to be a level of a Hillcrest or an Integris, that kind of thing.
I'm last but not least here, and really this is just going back to Senator Stanzlowski's question. I think we all got wrapped up kind of on wording here. So you're calling what I would call healthcare coverage, which is insurance, whether that's private insurance, Medicare, Medicaid. I guess in your world it's called a resource, and there was a slide that you went through that I wanted to make sure that I understood what it says. So I guess trying to make it simple for my little brain. it appears from the numbers that you put here, because you go through the population of uninsured in Oklahoma, then you go through kind of the population in, it's the Indian healthcare system in Oklahoma is the head, if you're looking for that. It was right before the, facility purchase stuff. Yes, here we go. If I understand this slide correctly, if you put together Medicare, Medicaid, and private insurance, the Native American population in Oklahoma has a higher percentage of some form of health coverage than the non-Native American population in Oklahoma. Is that what this slide is telling me?
I think that's a true statement, yes.
Okay, can you say that?
Yeah, I do.
Okay, all right, that was my only question. I just wanted to make sure that I had that right in my head. Okay, with that, we have tested everyone's bladders. That went longer than I think we thought, but I thought that great questions. I appreciate the presentation. We are going to take a 15-minute break. When we come back, we're going to talk specifically about Medicaid. And we've already gotten into that some, so I think that will go pretty quickly. But I want to make sure everyone leaves here understanding this 100% and how that does and does not work, because I think that's important for this task force moving forward. So we will be back in 15 minutes. All right, thank you guys very much. Before we move forward, I want to go back to Chairman McIntyre. I think he has one more follow-up question.
Thank you, Mr. Chairman. I'm going to come back and revisit the question that I asked you after speaking to you over the break. In this work group, we've talked, the uninsured rate has been presented to us, about 14%, the uninsured rate. And the question that has been circulating in almost every one of these work groups is Native Americans are included in that uninsured rate. And can you address that? I mean, what role do you guys play in that? Is it fair to even have an uninsured rate with Native Americans included in it?
Thank you for the question. And I think, I have to reflect a bit back on the overview that we gave earlier, in that the IHS, although it's an obligation of the federal government, it is not a guarantee for any kind of set of services or benefits that might be provided to a person, and is not considered insurance coverage, probably for that and a whole lot of other reasons, but certainly that. I would also add that, as Senator McCourtney raised earlier, actually we bring the overall uninsured rate down because the percentage, a proportion of our population is actually less than 14%. It's below 10%. So we actually bring that rate down. And I think one of the major reasons why is that we work very hard, as Melissa said earlier, at exploiting every resource that a patient has when they walk through our door. So every time they walk through our door, they see a patient benefit coordinator that goes through, okay, do you have private insurance? Do you have insurance at your work? Are you eligible for VA? Are you eligible for Medicare? Have you not signed up? Because maybe you don't think you need to sign up because you have Indian Health. These are all the reasons that you need to have coverage, because we cannot provide all those services to you, and we're not a guaranteed resource for you, although we will do everything in our power to do that. So with that, I'd ask my colleague here if she has anything to add.
So I agree 100%. I just would add, if we were at 150% of funding versus 39%, then maybe I would have that conversation. But at the moment, we're citizens of Oklahoma, just like everyone else is citizens of Oklahoma. The Indian healthcare system only provides primary care for the most part. And if we want to access health care like everyone else is, then we need a resource. I've had health insurance as much as I can. I will continue to do that because I can, you know, I'm 60 years old and I'm getting chronic issues, and I'm probably going to have to be sent to a specialist here before long. It's just part of our DNA, I think. So, yes, by far, we should be entitled, not entitled, I'm sorry, I hate that word, but we should have the same access as everyone else, and we definitely should be counted the same as anyone else. You know, there are a lot of non-Indian people that have some access to primary care through community health centers, FQHCs, OU free clinics, you know, university-sponsored, other free clinics. I mean, there's a lot of access to primary care, access to care. And should those people be counted in the uninsured? Absolutely. Thank you.
Follow up.
Thank you, Mr. Chairman. So, okay, that was enlightening. So would you consider what Indian Health is? It acts a lot like an FQA, a federally qualified health clinic. Would you say that you guys operate and what you're giving is free care, not insurance?
Yes, sir.
Go ahead.
If I may follow up, and I may be getting too much in the weeds, but you can stop me. But I would even go a step further and say that for Medicaid purposes, in the statute, it deems IHS and tribal facilities as FQHCs, tribal FQHCs.
Very interesting. Okay. Thank you very much. If you guys would like to move on to kind of we've already gotten into some of this. But I wanted to separate out Medicaid for this conversation because this whole 100% question is something that is hard to understand, but I think essential for us to understand. So if you would briefly go through this presentation, and then I can guarantee you there will be questions.
Terrific. I will start, and then I'll pass it to Melissa here. Just to start from a Medicaid focused discussion. And if we're talking about potentially extending eligibility up to the limit, 133 federal poverty limit, the 100% FMAP, to be clear, would continue for any expansion population. So it would not only be for the traditional Medicaid population, but any other population that would be covered in the future. So it doesn't distinguish one from the other in terms of whether the state would get 100% federal match. It would increase the federal matching rate from the current rate of 62% for traditional Medicaid to 90% for services for the expansion population. So, for instance, we have mothers and children, some of those obstetric services, et cetera, and we'll get more into this, that will move from, or could move from 62% federal match to 90% federal match, and that makes a savings to the state, and we'll get into that very specifically in a moment. There's a host of benefits, and when we talk about getting people coverage, we're reducing uncompensated care, and this occurs, of course, in the private sector. Somebody goes into an ER, you must see them under EMTALA. They don't have any kind of resource to pay for that service. It is uncompensated care. And we see, of course, we have an ER. We don't only see natives in our ER. Of course, we under EMTALA, like everyone else, they come to and present to the ER, we serve them. So uncompensated care really does cut across the board as well. So in addition to that, just in general, people have asked us about how many American Indians, Alaska Natives would be covered under that scenario. We've had numbers of 44,000 is in this. It's been from 34 to 44. I would say that would be the range. 34,000 to 44,000 American Indians, Alaska Natives fall into that breadth of the FPL. In general, just to talk about low-wage folks in Oklahoma. Low wage doesn't mean no wage folks in Oklahoma, and if the FPL were raised to 133%, you're capturing in a lot of the working poor in Oklahoma that can't afford insurance even on the marketplace. There may be some low-cost insurance out there that some folks can get if they're really destitute, but if you're a worker in Oklahoma, you may not still be able to afford that. So if this scenario were to play out, an individual in a single-person household could make $8.29 an hour and qualify. A couple with one worker in the home could make as much as $11.22 an hour, and a parent in a four-person household could earn as much as $17.08 an hour and still be able to qualify under that scenario. And then you think about how this plays out also for small employers in Oklahoma that are trying to insure their employees, which is an expensive proposition. So just it would relieve some health insurance costs for those employers and those employees. For example, a person in a four-person single-income household, they'd have to expend up to 30% of their income on the premium for self-only coverage and would be liable for up to $7,900 per year in out-of-pocket costs. So for a person that is making minimum wage, that is really not affordable. You cannot spend 30% of your income for premiums. So you're needing to spend it on housing and everything else, which is also very expensive. For small employers, providing even a high deductible health insurance plan is a significant cost. It would add about $2 per hour per employee, which is about a 30% increase for a minimum wage employee in order to provide that benefit of health insurance. So for small employers, it can get really costly, and Medicaid expansion potentially could help with that. So these benefits play out not only in the direct health field, or those of us that are providing direct care and uncompensated care, et cetera, but it means real things to your average resident of Oklahoma. So now I'll have Melissa pick up with funding for Medicaid expansion.
Thank you all. Hope you had a nice break. I did. I got to walk around and move around, and it was nice. Thank you for that. So, Melissa Gower, Chickasaw Nation. I just wanted to talk a little bit about the expansion of eligibility, right, for Medicaid. And, you know, I know that's a tough word and one that is tough for me to even talk about at times. But really the focus and why we wanted to have this part in here is because we want to talk to you a little bit about some of the savings that the Indian healthcare systems can help in Oklahoma in those revenue streams. So that's really our purpose for doing this. It's really not, you know, you guys are the decision makers and the lawmakers. It's not, we're not here really even to debate that or not. Expanding eligibility. It's really more about, we wanted to talk to you about the savings and the Indian healthcare system so you understand the revenue streams, or, sorry, I don't want to use the wrong word, but whatever it is for that. So basically, we didn't do any new studies, but we looked at the studies on the OHA website that the Mannett Report and the OSU Center did, and really saw that there were a couple of different revenue streams, I think, that everyone's kind of looking at for this. And of course, one of those was program savings, which Melanie just talked a little bit about. And it kind of goes to, and I'm sorry that I forgot your name, sir, on the front row. It kind of goes to what you were talking about. Sorry about that. You know, that some folks that are on 62% on programs match, I'm talking about match, right? Because that's what I want to talk about, are going to move to 90% match. So there's that between the 62 and 90% that's going to be saved now, or different. I don't know what the right, we had a discussion about what that term is, right? Whether it's a savings or not realized or whatever the term is. But anyway, and that's, the things like the breast and cervical cancer patients that are currently on that specific Medicaid program. There's programs that are currently funded 100% by the state that would now move over to that. Things under the mental health and substance abuse, we talked about that. The Department of Corrections, the public health services under the Department of Health, like immunization programs and those kinds of things that are going to move over. And then the second piece, and Melanie just talked about that, was just the increased revenue from, the generation of economic activity. But what I really wanted to talk to you a little bit about was the third piece, which is the Indian-specific things. And this is where we talked about, the difference between the 90% and the 100% that he and I were discussing at break, and would that, not be required to be matched now by the state, that 10%. And I believe that is absolutely true. So thank you for even bringing that up, because as you see, I don't even have that on my slide. So I learned something today. I'm excited. So that's great. And then, the other thing is we've talked about any service provided in an Indian healthcare facility or referred from an Indian healthcare facility. The law says through, but I'm going to say referred from, because that's what through means, right? Is recovered by the state at 100%. So that's your difference between your 90 and your 100. Those services have always been 100% since 1976 and will remain 100%. The expansion, we believe that only in 2017 did CMS start allowing the 100% FMAP for the receive through. Before 2017, we didn't do the receive through. It wasn't allowed. But in 2017, CMS, I believe it was January, made a new policy and started allowing the 100% FMAP on receive through. They have requirements for how you do that. And basically, there's 4 components. And they're really brief, and I don't have them in front of me or off the top of my head, but I can tell you basically what they are. That has to be, the Indian health facility has to have agreements with your outside providers that you're sending those people to, that you'll do these 4 things. One of them is sending you copies of their records where they saw you. We already do that. When you get referred out, your specialty physician 99% of the time sends your PCP a copy of their report, right? So that's one requirement. I mean, it was things we're already doing, so it wasn't any issue. And we already have contracts with all the people we send folks out to. We have contracts in place. And so it was making sure you have those what their CMS called care coordination agreements, okay? And Indian Health's been doing this for years. CMS just finally caught up with it, is really how I like to say it, because we've been doing it for years. So if you have these care coordination agreements and someone is on Medicaid, when we go in and do the Medicaid referral online, our patient benefit person, they check a box and says, we have a care coordination agreement with them. And that would be anyone we refer to, because very seldom do we refer to someone we don't have a care coordination agreement with. And when that gets to the state, starting in January of 2017, those claims can also be matched at 100%. So I say that because that's kind of a new revenue stream for the state of Oklahoma. It's claims that were currently before 2017 being matched at 62%, and the state was paying 38%, that are now going to be matched at 100%. So the state's already saving that 38% on all those claims. Now, I can tell you that we have been working with the Healthcare Authority for a couple of years trying to get that implemented in all the Indian healthcare facilities in Oklahoma. We're not there yet. But we have that on our list to continue to try, and during every month, we go to OHCA and our tribal consultations, and we talk about how we can make sure that's implemented. But the Indian Health Service, who's a provider in the state, right, they've implemented it 100%. The Chickasaw Nation and the Choctaw Nation have implemented it 100%. So we're proponents of the program. But that is a revenue stream that has not been there before and, is there that could help to cover some of those patients. And that's projected, and that's in addition to the $88 million that was previously saved by the state every year. And the other part of it is that new revenue into our health systems from that revenue source stream would allow us to continue to expand our access to services, bring more of those specialty services in-house, and to add additional healthcare services. You saw, the Chickasaw Nation, we have a new hospital that we built, 9 years ago now, I think. The Choctaw Nation just opened a new health center not long ago in Idabel. The Cherokee Nation is actually getting ready to open one in October, I believe, in Tahlequah. And so we're already trying to add new facilities, but that additional revenue that helps us get above the 39% funding level, right? Because Medicaid, Congress intended Medicaid to supplement our funding, to raise that up a little bit, would be that funding source, and it would all go back into our health systems to help us expand access and to increase our facilities. So, really, I think with that piece of it, it's really more beneficial for the state, and we just wanted you to see how we contribute to that, how we will continue to contribute to that, and that the partnership that we have with the state is important to us, and we want to continue working on that. One of our biggest people that we work with nationally is the tribal folks from Alaska. They have a large policy and legislative contingent, as you know, and so we work really close with them. And I just wanted to share this because he just told me this a couple of weeks ago, that they just completed their post-evaluation on their initial projections, and it surpassed their initial projections, and in Montana also. And then I just want to leave you with my summary slides, okay? So this isn't really about the particular health care, but as you know, through the self-governance and self-determination by the tribal sovereign nations in the state of Oklahoma, our tribal economies have seen increases in tribally owned enterprises, in individual citizen-owned enterprises, which we work really hard with our citizens to help them have citizen-owned enterprises. And as you all know, we do serve local and tribal and non-tribal communities. All of our communities, our households, a lot of times are made up of tribal and non-tribal members. So we serve all of those various demographics. And the investments that the tribes make in economic development and job creation, provides mutual benefits not only to the tribal nations but to the state of Oklahoma. In fact, the 39 tribal nations have about a $10.8 billion impact on the state, with that supporting about 85,000 jobs, or 5% of the jobs in the state. And the tribal health care facilities make up a significant part of the workforce opportunities, which I think you've all gained through our information that we've been going through. So the tribal population is indeed a human and economic asset to the state of Oklahoma. And I just want to say in closing that Melanie and I both appreciate you all so much. We appreciate you being here this morning, indulging in us. As you can tell, I like to talk, so I can talk all day about Indian health care. And it's really nice when I get someone that really wants to listen, because it just makes me want to talk that much more. So Thank you for your indulgence and your kind comments, and we hold each of you in the utmost respect, and we pray for your continued journey. Thank you.
Thank you very much. I'm going to go first. And I want to focus specifically on point number 3, and if you can pull that. And in all honesty, I think points 1 and 2 are best left to the Chamber of Commerce and to the Medicaid agency itself. But point 3 is very much why I wanted to break this out and try to make sure. And this is the second time I've heard a presentation on this, and I think I'm starting to grasp. So first, you say, so if someone has Medicaid, now that's not just through expansion, we're talking about today. Right now in the state of Oklahoma, there is most likely a female who's showing up to a hospital to give birth to a baby. And given statistics, there are very good odds that that baby will be born and paid for through Medicaid. If she is a tribal member, or if the father is a tribal member, and this is putting together your earlier presentation and this one, then that child, that birth should be paid 100% by the federal government with no funds from the state of Oklahoma at all. Is that correct?
No.
Okay.
What
please
is
help me.
correct is if that mother was, if the hospital was a tribal hospital, it would be, yes.
Okay.
If the mother went to a private sector facility and had a referral from the tribal hospital, yes, it would be paid at 100%.
Okay, so going back to Representative Fugate's example earlier, Western Oklahoma, he asked if you go to get care in Western Oklahoma, would it be covered at 100%? Your answer was probably not. And that is because the referral does not exist. Why does the referral not exist? If it is, so I mean, let's say it's the hospital in Guyman, and you have a contract with the hospital or a care coordination agreement with the hospital in Guyman, then what stands in the way of there being a referral for that care that would get this to 100%?
There would be nothing that was, if we had a care coordination agreement with the hospital in Guyman, and that patient usually comes to us, and we give them a referral, a sheet of paper that's referring them, or one we faxed, or one we've, whatever. I don't know how we send them nowadays, probably through Facebook, who knows, I don't know. Just kidding. But if they had the referral and there's one existed, it would be paid 100%. I think what I was referring to when he said that, and maybe it's, again, this is a misinterpretation probably on my part, but I was assuming if someone lived in Guyman that they did not have a relationship with any Indian healthcare facility. So me as an Indian person could be living in Guyman. I don't have access to Indian healthcare because there's nothing close enough, right? So I never go to them. I go to private healthcare system. That person would not have a relationship in order to have a referral.
So that person would have had to have seen, assuming it's Chickasaw Nation, since I'm talking to you, if it's a member of the Chickasaw Nation, they would have needed to have seen a Chickasaw Nation doctor during that pregnancy to then kind of be in that referral pipeline, for lack of a better term. Is that correct?
Yes, yes. So a really good example is, if I lived in Guyman and I was Chickasaw, I could go to the Chickasaw Hospital, establish a relationship with the OBGYN. They tell me I'm pregnant. And I'm not going to say this will happen, but I'm saying it could. So they say to the doctor, I live in Guyman. It takes me 3 hours. I don't know how far it is, but it takes me 3 hours to get here. Can I just see my local doctor in Guyman? And the doctor could say, sure, we'll give you a referral, and you go to that doctor. And that referral could be, one referral could be for a period of the pregnancy with 6 weeks postpartum, and that could be covered at 100%.
Could that establishing visit be done by telehealth?
As far as I know, anything can be done by telehealth if the access is there.
Okay, so at the bottom, point number 3, you have projected 9.2%. If I understand, that is the state share of Medicaid expansion that you're projecting there. Is that correct? I just want to make sure we're talking about the same numbers
I'm
here.
sorry, could you say that?
So I guess maybe it'd be easier, when you, at the bottom of point number 3, it says it's projected at 9.2%.
Yes,
That's
sir.
9.2% of what?
Of the cost, of the projected cost of expanding eligibility.
Okay, so if the projected cost to the state of Oklahoma of expanding eligibility is $120 million, then your projection is basically that it's going to be right around $11 million in cost savings that the state of Oklahoma could
Yes, sir.
get through here.
Yes, sir.
Okay, so my final question, and then I'll start looking around, would be, or if Representative McIntyre wants to start looking around while I ask, one of the problems, one of the things, if we did decide to expand Medicaid, is we have to be able to tell the federal government where we're getting our 10%. We can't just say, oh, we promise we'll find it. We have to say this is where we're going to find it. In your experience, I know you work with a lot of states, have states been able to use this cost savings as part of will the federal government count this cost savings as something that is, I'm going to call it bookable in a Medicaid expansion or any kind of other, kind of really a waiver program is where we would have seen it if it exists. Do you know of any state that's been able to do that?
We can't confirm whether a state has actually proposed such a thing before. I guess my thoughts on that subject is in the same way that you would capture the cost savings of the 90% match. This is a very similar thing. It's just a different scenario. You're capturing the cost savings for those services provided through Indian Health. And what we built our projections based on was on the current facilities and the current level of care that's being provided. So no assumptions about, building lots of new facilities or any of that, although we do think new services will arise, but it is built off of the existing structure and the existing level of services that are being provided.
All right, then I'm going to go ahead.
And I will find the answer to that for you probably today. I can probably just make a phone call and get that from CMS.
All right, and I will grant myself one follow-up then. So going back to, I think what you just said, this 9.2% or this $11 million that we're talking about, that is not assuming that the state of Oklahoma gets any better at this care coordination than they already are. So there's actually more money on the table if we can figure out how to be better at that than we currently are. Is that a safe assumption?
So the projection there, it was based on a 1% increase for the first 5 years.
Okay.
So very conservative increase.
All right, thank you. Representative McIntyre.
Thank you, Mr. Chairman. I want to back up to your point one, and I'm a little confused. So just back up one slide. There you go. Okay, so we have, right now we have a traditional Medicaid population. They receive a certain match. If the state were to do something like expand Medicaid, that would be a different population, and it would have a 90-to-1 match. I'm confused here because it seems like you guys have calculated based on all the Medicaid population going to 90%, whereas that's not what would happen. Would you like to?
So I hope I explained this correctly in what you're asking. So what I understand, and again, this is not our original stuff here, right? Okay, so what I understand is that in addition to traditional Medicaid, there are also other programs that's operated by Medicaid that have different FPL guidelines. So like breast and cervical cancer, that's the one I know the best probably. And I can't even tell you what the FPL is, but it's pretty high. I mean, it's like 160 maybe % or something. And so currently, that population is being matched at 6238, right? Well, under expanding Medicaid to 133, the population that's on breast and cervical cancer that would be between 100 and 133 would transfer, that coverage would now be covered under the expanded eligibility population and be matched at 90% instead of the 62%. That's what I'm saying.
That makes better sense.
Okay.
Thank you.
Senator David.
Thank you, Mr. Chairman. And I appreciate you asking that question because I also had that concern immediately when from your previous question or discussion on point number one. But I also wanted to, you have coverage of women during pregnancy, and those, currently in Oklahoma, we cover that up to 185% poverty level. So they fall under our current population for that. So are you saying, so if it's a new pregnancy, so the children would remain because they're already in and they would be at the 62%, because we cover all children up to 185%, so that wouldn't change. Are you saying that the pregnancies, if it's a new pregnancy after the expansion, that would be covered at, that pregnancy would be covered at 90?
So maybe we need the CMS person in here, but my understanding, and again, this is not my information, this was just presented from the Mannett report and the OSU report that was done, that's on the OHA website, right? Mm-hmm. So just disclaimer, it's not my information. It is my understanding that anyone that is currently that the eligibility population, if it's expanded from 100 to 133, right? So anyone that falls in between 100 and 133, no matter what other program they're on in Medicaid, that they would move to the expansion population and be covered at 90% now versus 62% in that program. That's my understanding.
Follow up.
Okay, then I'm going to have to go on the assumption that that's kind of what we're talking about. Because if they're, like I said, we cover all children currently up to 185%. We cover all pregnant women up to 185% at the 62%. But I guess if that woman were to fall off because she's no longer pregnant and it's past that time, then she would, if she becomes pregnant again, she would fall into that higher, that higher rate at 90%. So I'll have to look into that. So it's still a little confusing, but you also had on this slide about the DOC population moving from 100% state funding to 90% FMAP. That will never happen. I mean, the or federal regulations are if you're behind a fence, then it's 100% state, no matter what. It's not until they get out of the fence that we can move them, and then we could. If they fall in that gap, we can move them, but they have to be out of the fence. So is that your understanding also? I mean, that's mine, unless somebody has anything else.
I can't speak to Department of Corrections, sorry.
Okay. Well, staff is telling me that's correct, so I think it is. So I didn't know if that was part of the calculations that we're looking at also, because that, like I said, as long as they're behind the fence, it's always 100% state funding. So that's all I had. Thank you.
Senator Quinn waves. Any other questions before we wrap up this session? Thank you guys very much for your presentation. Thank you for being here. I very much appreciate it. If you can get us, I'm trying to remember, you promised a couple of pieces of information, if you can follow up with that. I would also, I think everyone on the committee would be interested. You said Alaska's kind of gone before us on some of this, and they've actually exceeded expectations. Mm-hmm. Any information that you can give us on that to better understand what Alaska has done, I think would be helpful to our work going forward. Thank you guys very much. And with that, we are adjourned.